this is an important topic which is pertinent to all our clinical practice. This is what we do every day, apart from doing joint replacement. So I'm sure everybody is interested in this topic. I would like to thank Dr. Pradhan and the organizers for having me here. And I hope that I'll keep you awake after this sumptuous lunch and post-prandial session. So I'll be talking about recent advances in intracapsular neck femur fracture. So mainly I'll be talking about what new implants we have, but more than that, the focus would be on what we have now learned about this fracture. What the pathology, pathomechanics are, how much, when to operate, when not to operate, and how quickly we need to get them out of bed. So I'll be talking about that as well, because that is an important recent advance. So learning objectives would be understanding the fracture, decisions in timing of surgery, when to fix, when to replace, what are the reduction techniques, and why certain implant scores over the other implant, what is the current literature saying, and how to plan our fixation. And of course, we'll be glossing over the literature and results, and of course, some scenarios which are again very relevant to our practice. So, poor femoral head has a very precarious blood supply, and unfortunately, the vein arteries don't allow it to heal very well. So, the result is always very compromised. So, we cannot challenge this, so we have to live with this anatomy. And as we all know that femoral head has to balance twice the body weight, the abductor lever arm has to balance it. So there are tremendous amount of torsional and bending momentum working on this femoral head. So the fracture itself is very, you can say, already hanging by a thread. Also the healing is poor because of the poor blood supply, absence of periosteal layer, and it only heals endosteally. So periosteal healing is not unfortunately available. And the synovial fluid, there are theories which say the synovial fluid prevents hematoma formation. And there are, as I already said, that there are tremendous amount of shearing and torsional forces. So, coming to classification, we'll quickly go over it. AO classifies as 31B. Then the famous Gardens classification, which talks about bending of the trabeculae and displacement of trabeculae. Then the Powell's classification, the verticalness of the angle of the fracture. More the angle, bad is the outcome. And as told in 70s that these kind of fracture patterns give you poor outcome. So type 3 Gardens or type 3 Powell's gives you bad AVNs or bad non-unions. So anyway, the fractures are very bad and the outcome is compromised, but we have to give him a better result for the patient for him to get a chance to heal it. So these kind of fractures we see routinely, the impacted neck femurs, where in doubt, just go ahead and do a MRI because CT scan or X-rays won't lead us to anything and the fracture will be revealed. So the biggest question is when to fix. The conflicting literature and what we traditionally learned was should be an orthopedic emergency, should be done in 6 hours. So within 6 hours, within 12 hours, within 24 hours, daytime, nighttime if it is emergency, and do you really need to evacuate the hematoma? So there are literature now says the meta-analysis where they have studied thousands of patients of fixation of intracapsular fracture and have compared 6 hours to 12 hours, 12 hours to within 12 hours, after 12 hours. Multiple studies now have come to a conclusion that intra-articular initial fracture displacement is going to decide your outcome. Whatever you do, whatever you fixation method you use, the initial displacement, the disturbance in the blood supply is going to decide your outcome. And fixation method can change. We'll see that in our consequent, slides. The quality of reduction is going to decide your outcome. And there is no association with timing of surgery versus AVN. There is delayed in surgical fixation can lead to slight higher chances of non-union. So that is what we understand now with intracapsular fractures, that you don't have to go in and operate at 12 o'clock in the night. So you have to have adequate personnel who are trained to do that, equipment, good CM person, instrumentation, implants, whenever that is ready, you should go ahead and operate and as early as possible. So generally within 24 hours with all the setup ready, okay? And there is no proven role of hematoma evacuation. What determines outcome is your reduction and it directly correlates with the perfusion of the head. Timing of surgery, as I said, doesn't matter. Within 24 hours is sufficient. Now which surgery, whether to fix or replace? And there has been again conflicting literature available. The patient factors, the patient osteoporosis, medical comorbidities, what was the pre-fall ambulatory status of the patient? What is the displacement? These are going to decide what kind of surgery you are going to offer. So usual consensus is 65 years or less, we try to fix it. And somebody who's 65 but physiologically 75, we don't offer them fixation. We try to replace them and get them out of bed as early as possible. But usual consensus world over is 65 to 70, you can say, for fixation, otherwise replacement. Now, when you replace, what to do? Hemi or total? Again, that's a big dilemma. And enough literature now available says the results are good with both, and better outcomes, slightly better outcomes at 24 months with replacement. Slightly, you can say, adverse effect more with total hip replacement because the patients are more active. They tend to fall and get periprosthetic fractures. But you should be talking with the patient about their goals, what their expectations are from the surgery, and then decide which surgery you want to offer, hemi or total. Okay, may not be available for all. Those centers where they don't do total hip replacement routinely should not be offering this. And of course, cost is a prohibiting factor. Now, coming to fixation, what's new? Now, before going to fixation options, so you should not be doing multiple attempts. The traditional Whitman method will be stabilize the pelvis, pull the hip, do rotations that can deteriorate the outcome further because you are damaging the blood supply. So no multiple attempts, you should be giving gentle attempts. Reduction should be ideally done on a fracture table. And now we know the fracture patterns are commonly the head is rotated posteriorly, the leg is rotated external rotation, and you need to counter and neutralize that. The classical lazy S pattern, if you can achieve by reduction, is ideal. Fracture reduction, if it is not coming, you should not be having a low threshold for opening anteriorly with mini incision. Go like a mini Smith-Peterson approach, use bone hooks or spikes and reduce it. And try to achieve the Garden Alignment Index, what we learned traditionally in 70s. So try to get a good alignment, which is preferably in slightly valgus. So as we know, this head generally is in internal rotation, the shaft is in external rotation, and the medial calcar buttress is gone. Usually in lateral X-rays, the head is fallen posteriorly, and that is how we typically get the patients. So reduce them by internal rotation. By reducing, you should put pressure on anteriorly and try to reduce it so that the leg in lateral is in one line, and then you can plan your fixation. Or if at all it is not coming, then you should open anteriorly where the blood supply may not be getting compromised. You can use tools which are available with you. The traditional method of fixation, what we have seen is Moore's pins, Nowell pins, and now unfortunately we have seen they being inferiorly biomechanical properties, they fail. They migrate, they cause irritation and eventually loosening, and the patient gets non-union or avians. And this is what even cancellous screws do, because fracture pattern is going to decide your outcome. So technique in reduction, we have seen you should be operating as early as possible on fracture table. You should be trying to get anatomic reduction, close manipulations, open reduction if at all you want to do with wires, and then what the fixation options are. Let's see what the options we have. Fixation traditionally we have 3 cancellous screws, what we have learned. Then something called as, this is what the new philosophy is, biplanar double supported fixation, or BDSF. And we'll talk about that. DHS with derotation screw is the workhorse, which gives you predictably good outcome. Femoral neck system, now the new contraption which has come in with AO and other companies, the FNS. Then if you go further one step ahead, then medial calcar plate with screws, and of course sometimes intermedial nail with screws. So coming to screw fixation, what ideal position is? The recommended position is subchondral fixation of screws. They should be parallel. No screw entry traditionally below the lesser trochanter, and one screw inferior and posterior neck supporting the calcar. That's what we have learned, and that is what the traditional positioning of the screw is. And this still works, but now we understand it better. So traditionally the inverted triangle, which used to give us a good outcome, and it still holds definitely a position in fixation, but we have seen failures with this kind of fixation. Subtrochanteric fractures, screw migration, because the screw is mostly going to cancellous bone, the screws migrate backwards, and we lose the fixation, secondary loss of reduction. So now the new technique which has come is biplanar double supported screw fixation, or BDSF. What the philosophy is, as I said, in this kind of fixation traditionally, the screw used to be all the time in cancellous bone. Even the head is in cancellous bone, the screw threads are in the cancellous bone, and they don't resist the bending momentum, especially in vertical shear fractures, and they eventually fail. So what they recommend is you should be putting 2 screws from the diaphysis going up to the subchondral area, and these diaphyseal screws give you a better bending momentum, you have a better purchase in the diaphysis, and they are in line with the fracture. So they give you better outcome, and there are now 8 to 9 years of follow-up results available in literature. So ideally 2 beams of 2 screws you should be putting which can handle the cantilever better, And usually these screws are long. The average screw length is about 13 centimeters. So talk to your vendor and try to get longer canceller screws. So usually 13 centimeters of screws are required. The follow-up is now good. AOS does recommend as an alternate option of fixation. Lateral cortical fractures is a theoretical risk, and additional comminution can happen if it is a fracture of anatomy is very oblique. So that's the downside of this kind of fixation. The workhorse traditionally which has given a good outcome is the DHS with derotation screw, because you have an angular stable device with a derotation screw and there is some collapse which is happening. So DHS with derotation screw is a better option. Biomechanical is sounder option. So it gives you predictable good outcome, especially in basic cervical fractures, and you can start weight bearing early. But slight disadvantage of slightly higher rate of AVN with this. The new contraption, as I said, is the FNS, which has a smooth blade, angular stable device, and a derotation screw going in a different plane, and gives you high resistance to varus collapse. It implant doesn't cause any lateral protrusion because the collapse happens inside the barrel. So you don't have a lateral protruding DHS screw which is poking the patient. And it has a multiplanar fixation. So this is how it is. These are a few of the results. It's a good angular stable device. Control compression can be achieved. 15 millimeters collapse can happen without protrusion. But unfortunately, there have been some reports of subtrochanteric fractures with this. Anecdotal and case reports, but yes, that's coming up now. So you should be cautious about this as well. Then one step ahead is putting a Calcar plate. So people have gone anteriorly and gone to the buttress area and put a 1/3 tubular plate, a Calcar plate, which can give you better bending momentum right up to 6 p.m. position of the head. And this is what, and now Hospital for Special Surgery has come up with this paper. The few Chinese and Japanese literature also
Manish,
talks about it.
You need to wrap up.
Wind up? Yeah. I'm just, this is the last thing. So this is the plate, what they recommend. There's small scope in especially young adults who are athletes where you want to preserve the head. So these are the methods, what to do, the traditional literature review and everything as per the books and the literature says derotation screw with DH is a better mechanical stable device. FNS is equal or equivocal. Cannulated canceller screws can be used, but BDSS method is better. And diaphyseal entry of screw at 113 millimeter average. Calcar plate, rarely. Initial displacement is going to decide the outcome. Early surgery in daytime is preferable, not at night. Cannot fix an unreduced fracture. And open limited option reduction for better bony opposition. One small note about this, 30% of shaft femur fractures have a neck femur fracture which is found on table. So you should be always ready to see these kind of fractures in shaft femur, okay? Don't miss this. Stress fracture in young athletes who are running now. There is stress fracture in compression tension zone. If it is more than 50%, we should be fixing them. And failed intracapsular fractures or fixation method, you should be going for a distal fixation stem, not a standard cemented bipolar, because those are going to fail proximally. So distal fixation stem for surgery. And within 48 hours is the current literature says that you should operate in 48 hours. Don't wait for clopidogrel to stop. Thank you very much.